All right. Thank you for inviting me to present here. So today we are going to talk about building trust to achieve better outcomes in diabetes self-management, education, and care. I'm going to go through a few learning objectives. At the end of this presentation, you will be able to recognize the critical importance of the ADCES 7 self-care behaviors in diabetes self-management and health outcomes, describe how health centers can create trusting, collaborative, and person-centered care teams to engage people with diabetes in their daily care, and describe the different care settings and teams, migrant health centers, urban FQHCs, IHS clinics that are building programs of successful engagement, retention, and health outcomes. Just go over a little bit about who we are. Our name changed recently, but we are a multidisciplinary membership organization. We used to be the American Association of Diabetes Educators. Our name changed in 2020. That was a little rough timing because it was right as some other big things were happening. We have about 12,000 members organized at state and local levels. Our members have been working alongside people with diabetes since 1973, and we're celebrating 50 years. We believe that education and support and prevention should be accessible to everyone in all communities. We do work in prediabetes. We are a recipient of a CDC funding opportunity called 1705, and we also work closely with the National Center for Farmworker Health in that work. We also work with diabetes self-management education support and most other evidence-based programs and services that address diabetes, prediabetes, higher weights, and other metabolic conditions. How we do it. Our real focus is person-centered care. This is what our profession and organization are kind of built on. Strength-based inclusive language, I'll be talking about that a little bit more later. Reducing stigma for people living with cardiometabolic conditions. Peer support communities, empowering people, shared decision-making approaches, and connecting people with social determinants of health support. So just take a minute to think about, can your community health center improve person-centered care? And if you can, hopefully we can help you here today a little bit. And we also, really believe in a team-based approach, an interprofessional approach, seamless and holistic care that integrates clinical and self-management aspects, really promoting behavioral health professionals to improve quality of life, person-centered team and population health teams, integrating community health workers to extend care. So, think about, how does your community health center provide team-based care? I know you probably do, and there's probably a lot of ways, and we're going to really focus on diabetes education, prevention, and support today. We do this through aligning with evidence. All of our services that we promote and that our members are out there working on are evidence-based services. National standards for diabetes self-management education and support help drive the evidence base for diabetes self-management education support, or DSMES, as you'll hear me say, and then the CDC's Diabetes Prevention Recognition Program standards. ADCES also produces practice papers to help guide diabetes care and education specialists. So a lot of resources that we provide can help your community health center ensure effective and evidence-based care. The cardiometabolic spectrum is kind of where we touch people at all places, along with higher weights, preventing or delaying type 2 diabetes, supporting diabetes self-management education and support programs, and all of this preventing or delaying complications of diabetes. So I want to play a short video here next, just really talking about person-centered care. So we'll just take 1 second.
Person-centered care is an approach to improving healthcare quality, coordination, and quality of life. This approach demonstrates a move from the traditional medical model where the provider guides the care planning process to one in which the provider is assisting the individual in the care planning and assuring that the individual's preferences and goals are incorporated into their health and wellness planning. Person-centered care should also be facilitated through a dynamic relationship between the care team. The care team is made up of the person, relevant providers, and family members and/or loved ones who are important to the individual. This collaboration informs goal setting and targeted health and wellness outcomes to the extent that the individual desires. Let's look at an example. Robin is a 19-year-old woman who has type 1 diabetes. She visits her physician for her annual physical and explains that she has been having difficulty following her prescribed diet and taking her medications. In a person-centered approach, Robin's provider gathers information from Robin about her lifestyle and loved ones. Instead of solution finding, prescribing treatment, or referring, her provider attempts to discover why Robin is feeling challenged in following her medication and diet regimens. With Robin's consent, her provider requests a team meeting involving all care partners, such as Robin's identified loved ones, family, and/or friends involved in her care, an endocrinologist, a dietary nutritionist, and Robin's nurse practitioner. At the team meeting, they discover what Robin's goals and preferences are for her treatment and quality of life. Through the information they learn, it becomes clear to the care team that Robin's medication is having troubling side effects that prevent Robin from being as active as she would like to be. Her reduction in activity is causing her to feel self-conscious about her weight, and she feels unmotivated to follow her diet. The physician and the care team take into consideration not only what is important for Robin and her health, like getting the right meds, having a simple medication regimen, and eating the right foods, but also what is important to Robin and her goals, like being active, feeling healthy about her weight, and connecting with people socially and feeling in control of her diabetes. By understanding the components of what matters most to Robin, her care team can suggest meaningful, appropriate steps that Robin can take with both her lifestyle and her medical care. If Robin is supported to connect with health solutions through a person-centered approach, she will be more likely to adopt those solutions and experience a positive health outcome.
All right. I hope that helped kind of give you an intro and sort of think about, wow, yes, how can I contribute to that? And hopefully many of you are saying, yeah, that's exactly how we do things at our health center. But I think most of us are probably somewhere along that continuum. So I kind of want to move now toward just talking a little bit about what is DSMES, Diabetes Self-Management Education Support. Really, these are interventions that include activities that help support people with diabetes to implement and sustain the self-management behaviors and strategies to improve diabetes and related cardiometabolic conditions and quality of life on an ongoing basis. What are the benefits? We always have to talk about this. The benefits of DSMES are really providing that critical education and support for implementing those treatment plans from the provider, reducing emergency department visits and hospital admissions and readmissions, reducing hypoglycemia, all causes of mortality, lowers A1C, improves quality of life, promotes lifestyle behaviors, enhances self-efficacy and empowerment, increases healthy coping, addresses weight maintenance or loss, and decreases diabetes-related distress. And all of this with no negative side effects, and Medicare and most insurers cover the cost, and it can be reimbursed in a federally qualified health center. Critical service, but it's underutilized. So there is this call to action. Just have to mention this. And just the last thing I'll say is, if DSMES were a pill, would you prescribe it? Really looking at this slide, I have to credit Maggie Powers, one of my mentors as a dietitian and diabetes care and education specialist, who kind of came up with a sort of comparison of metformin, sort of the first line of therapy for someone with diabetes or type 2 diabetes, compared to DSMES or medical nutrition therapy. And you can see both are high efficacy, low risk of hypoglycemia, weight loss or neutral, no side effects with DSMES, sometimes some gastrointestinal side effects with metformin, but the cost is low or can save the health system or health center money when you're doing DSMES. Metformin's also low cost, and psychosocial benefits are high. So I want to give you a little bit of inspiration. Now I'm going to introduce you to a federally qualified health center in Indianapolis. Now they've been at this for a few years. But I just want you to see the potential of starting DSMES in a health center. And we're going to hear from Amy and Dr. Pino. I'm going to get that going.
Hello, my name is Amy Carter, and along with Dr. Dan Pino, we're going to share a little bit with you today about our DSMES program at Eskenazi Health, which we've had since 2014. So I'm going to go ahead and get started with our slide deck. All right. You may be asking yourself a little bit about why you might want to create a DSMES program or why an FQHC center might be so interested in having such program. Honestly, for us, it really came back to health outcomes. Our people living with diabetes in our health centers were definitely not as well controlled with their diabetes as we would have hoped. We had really cool resources. So we had dietitians and we had health coaches or we had social work, but no one was really working collaboratively together to really enhance the care of these participants who eventually became a very big part of our diabetes family. So as we looked at our program and our outcomes, we really targeted one of our healthcare sites that had the worst outcomes, really a high percentage of patients or people living with diabetes, and really a lot of opportunity for us. As you can see on the right, there's a little bit of information about our program brochure, maybe not quite large enough you can see it, but definitely we really built our program to be very inclusive of all of our team members with the hope that combining everything together would really make a good focus. As we looked at our staffing model, the very first thing that we knew was we wanted everyone involved. So the graphic on the right will show you the graphic on your left will show you a little bit more about what resources we had available to us. And then on the right, you'll be able to see exactly how we formed our team. In the beginning, we didn't have as many physicians involved, as you'll hear a little bit more about. We were really focusing on using our dietitian as the person who was going to coordinate the groups, the person who was going to really be the glue that held the program together. So they do most of the administrative functions, a lot of the patient recruitment, and then really focusing on bringing in the subject matter experts. So when we were talking about healthy coping, or when we're talking about medications, when we're talking about exercise, we really do bring in the people who are going to bring the most content. And the other side of that is making sure that a person who's entering our program also meets all of these people so that along their journey for self-care, they have the opportunity to know, oh, hey, I remember the lady who came and talked about mental health. She can probably help me with that. So definitely we created a very inclusive model. I'll be really honest with you. I know people who have created FQHC models with one person. So just because this is the model that we chose, don't feel for a second that you have to have all of these people. It'll just change your approach a little bit. I'm going to actually turn it over now. Dr. Dan Pino is our medical director, and he'll share a little bit about what we really looked at in terms of keeping our program, getting things built, but really how we talked about integrating that provider and how we looked at taking staffing from a small group of people that really built a program to making it an even bigger program. So I will turn it over to Dr. Pino.
Thanks, Amy. And as stated, I'm fortunate enough to be able to work with Amy and our fantastic team of dietitians and healthy meat coaches in overseeing how we're going to approach this type of behavior change and programs like this that we facilitate behavior change throughout the system at Eskenazi Health. As she mentioned, one of our goals was to always keep in alignment with our organization's goals and how we want to be approaching patient participant care. And one of the aspects of that is certainly meeting all health outcomes to a desired level that would be the standards of care. And so certainly our main focus is always going to be making sure that we have that as the forefront of what we do. But in addition to that, there's a lot more components to what we tend to see on a day-to-day basis, and this is something that all of you would be aware of. And part of that is about being able to facilitate these groups and opportunities for exams, getting involvement from those that are not typically involved, but would be important aspects of understanding each person as they walk through the change that they're looking for. And then finally, you want a sustainable model that can be reimbursable, as well as one that is seeing outcomes that will provide the funding that will be able to let this be something that's not just a one-time event or even a year-long event, but something over a lifetime we can see change, and that the clinic and the organization also is able to continue operating in such a way. And so once we found out that providers wanted to be involved, and I would encourage you, for those that are in FQHCs, to start that conversation, because there's often enough space for those like myself that are yearning to be in situations like this and can find value in being there with you. So that's something we took on, and what we tried to progress through is understanding how we can integrate that well. And in doing so, we found out that there was really an opportunity to see all those actions return a larger investment in how we give care, as well as how those that are participating understand what they're doing. And then finally, the aspect of finances that was really important, as you'll know, in any type of opportunity such as this. In our organization, we had already been focused on team-based care. And when we began this process of integrating the DSMES program, as well as those that had already been doing them in our system, we found that it was an opportunity for the team to grow. And in that, we tried our best to make sure that we were optimizing everything that each member was doing. This meant making sure that when a provider was available, that we were doing it intentionally and in a space that was really specific to what the provider would typically do in giving care to these individuals. But also what we wanted to see is, how did our nursing staff interact with our dietitians? How did our team interact with our pharmacists? And what were the opportunities for us to be surrounding each participant with the care that is needed to make lifelong behavior change that can lead to the outcomes we were looking for? And as you see, what we were able to do is find a pathway for the provider to be involved, but also in doing so, we found an opportunity for things like billing that was maybe not there in a group type setting. And in monitoring what was being done, we found that this was an opportunity to see that what was happening was we were increasing the support visits. We were giving more satisfaction to the patients and the participants that came into those groups. And ultimately, we saw that those like myself involved were having a better experience in what they were doing. And in doing that, there was certainly a place where we were finding that the opportunities for billing was improved. So it's certainly something I would consider in anything that you're trying to accomplish in your clinics, but in being confident that whenever you do engage in these type of practices, you will see the return in a tangible and a really significant way.
Thank you, Dr. Pino. So as we may have shared with you in this very brief moment, we built a program with a group of participants that really came to us in a very poor state. Our quality outcomes were not good. Their quality of life was probably equally just as bad. So one of the first things we really did, and we think is key to sustaining the DSMES service, is actually addressing the social determinants of health. So one of our biggest focuses at this point is really working with participants to do some very simple surveys to understand what their needs are and what their barriers are, because the best education in the world might still give you a poor retention rate in your program, or it might still not give you optimal outcomes that you need to sustain your program. So we really have found that addressing those social determinants, how are they going to get to clinic? How are they going to pay for their medications? How do they rate their education? Do they need internet resources? Because a lot of those things are now readily available to our FQHC patients. So as we look through, really we've focused a lot on this work And we do notice that it does help us with all of the things that I mentioned. The second part, just as Dr. Pino explained to you, when your leaders are able to hear from you about your goals, your outcomes, and your successes, it's golden. Not just for the bottom line, but also for everyone feeling that we're doing the right thing for the participants in our programs. And obviously, when there are challenges, be honest and open with your leaders, because what we've learned is that our leaders, our CEO, all of the folks in our organization are able to say, hey, well, how about if we were able to do this for you? So certainly don't hesitate to ask the questions and throw out the, wouldn't it be great if someone could help me with this? Because we've actually helped build a better leadership team support for our programs over time by being very open and honest about where we're winning, but also where we need help. And then obviously, as we're looking forward, one of the most recent things that we've heard from HRSA is that FQHCs need to be prepared for this transition to value-based care. It's in all of the newsletters, it's in a lot of the literature that they're sending out. So obviously, health outcome achievement, this type of care model, is going to be something that's increasingly important for FQHCs as we continue down the road. Right now, when we can get paid just because we saw someone today. Now that's not all no one here achieves, that's not our end goal. But when we can look to the future and we can say, it's not just because they showed up today, but it's how well we took care of them, a service like DSMES is going to be increasingly more important for us. So if we look back since 2014, our program has now about 7 years in the bank, and we're still seeing very, very good outcomes. The average participant may see their A1C go down 1.5%. We're seeing that they're staying with the program. We're tracking them through a year. They're engaging in our billable dietitian visits. They're engaging more with their providers. They're coming in as they need to for care. And they're also seeing our pharmacists for medication management, which definitely helps as well. Overall, I think that all of the things that we started with in 2014 has definitely, we've met our goals and we continue to increase them. And just like you'll notice if you do one of these programs, the participant satisfaction is typically through the roof. They love engaging with us just as much as we love engaging with them. So hopefully we've given you a few things to think about. And I will say that certainly if you're interested and have more questions, you can certainly reach out to myself or Dr. Pino. We would be very happy to talk with you further about some of the things that we've learned along the way. But thank you for listening to what we had to share with you today, and have a great rest of the presentation.
All right, so hopefully that was a little bit inspiring. It inspires me. Just want to point out some key takeaways is really focusing on addressing social determinants of health, gaining leadership support, and discussing value-based care transition. My favorite quote from the whole thing is, it's not just that they showed up, it's how well we take care of them. So hopefully that gets people inspired. But we're really going to talk today about really connecting with people in your community. And although sort of one of my goals is in my role is to help you increase DSMES services, we're really going to start small here and just really connect with people to begin with. So one of the things we focus on is really meeting people where they are, really trying to understand every single person has different circumstances. And though as professionals, sometimes we kind of see a lot of the same things come up, we really have to look at every person as an individual and meet them where they are. So I want to talk a little bit about building a rapport, and I took this slide from my colleague Jody, who who moved on at our organization, and I took her role, and she kind of helped get me started here at ADCES. And I just love this because it's so practical. Really filling the tank, which is the relationship with gas to keep people moving forward. So how do you build that rapport? Start with the G, get their story. Simple as just tell me about you. If you're meeting someone new that you don't know anything about, just learn about them. It doesn't have to be tell me about your disease state. It doesn't have to be about just tell me about you. Ask. The A is for ask about their values. What's important to you? Because what's important to one person may not be to another. And I think about when I was providing DSMES in clinical settings, there were very different things. I remember talking to gentlemen that would say, I just want to live long enough to walk my daughter down the aisle, or mothers who would say, I just hope to get to see my grandchildren someday that aren't even born yet. And so really understanding, or maybe it's just like the woman in the video where she really just wants to be active and feel comfortable in her own skin being active. So really understanding what are their values, and then us to seek to understand their concerns. When I think about diabetes, the simplest question can be, what's the hardest thing about managing your diabetes? Now, don't expect a simple answer, because that is a conversation starter. And at that point, you're going to hear a lot. And that is when you start to build that rapport. But the other key to this is you have to listen. A lot of times as we're talking, we listen for the next opportunity to speak. And I think it's in our helper professions, it's something we want to help people, but I think we have to step back and just listen and let people speak so we can learn more about them. Understanding their lives in context. And so, looking at this woman here, things we don't know if we don't ask her the questions is that she's a single mom of 2 daughters. She works full time. She wants her kids to be active, but she also wants them to stay safe. She wants to send them out in the neighborhood, but they don't necessarily live in a safe area. She loves to volunteer for a community garden. She uses your food pantry every week. She used your affordable connectivity program to help her kids with school. She was diagnosed with type 2 diabetes in 2020. She wants to lose weight. She sees a primary care health provider at your health center and wants to learn more about her diabetes. So these are all things that, you in the health center probably understand the context of her life, but making sure we do understand that context so we can support her, because offering her something that isn't family centered, that doesn't involve her family, may not be as effective. So just kind of building on that, how do we keep people coming back? Because what we want to do in any type of healthcare environment is create a welcoming environment. Smiling, I think we are so busy. And I know when I worked in the clinic, I remember at one point I had some back pain, and someone said, you don't smile as much as you used to. And that's when it really hit me, because I'm usually a pretty smiley, happy person, very positive. And I thought, oh my gosh. And I could tell there was a difference in my communication with people. And so I really focused on that. Even though I was in pain, I thought, I got to remind myself to smile, which is not something I've normally had to do. Some of these things are obvious, but when we're working in the context of our day, they're not. Be friendly and welcoming. Listen more than you speak. Talk with the person, not to them. And building community. I look at this in every sort of setting I'm in is really trying to be inclusive. Providing ample opportunities for people to share, and listening and encouraging. I think in a healthcare setting, sometimes maybe you're a community health worker that doesn't have, you're not a physician, you don't know all of the medical prescriptions and things that they might need, but you can do all of this. Anyone across the continuum of care can do all of this, because it really is just being human and giving someone that respect in space to share. Something else to really think about is nonverbal communication. Read the room. In a one-on-one setting, it might be a little bit easier, but we can also lose sight of this when we've got an agenda. And so I always encourage people, step back from your agenda and just listen. We will get to what this person needs. Looking at their facial expressions, their body language and posture, personal space. Some people feel very comfortable being really close. Other people, you can just sense they back up as you get close to them. I'm a hugger, but I'm not going to go into a room of people I don't know and start hugging people, because some people that might be really hard. You have to know, is that comfortable? Eye contact. Sometimes making eye contact is important. It often is, and in some communities it may not be. So really paying attention to these cues. When you look at this gentleman, I think of someone that may be sitting in a classroom where I was providing DSMES or diabetes education or support, or just maybe walked into a clinic room while I was asked to support the physician and some guidance, and I walk in and this is what I see. I'm sure you can kind of think of some things. My first thought is, I don't know, but he looks worried. He looks maybe a little bit angry. His arms are crossed. And I'm thinking, okay, I got to figure out what's going on here, because he's either scared, angry, or worried, just based on the furrowed brow and the body language. And so this is something we want to be very conscious of. And and get comfortable with addressing, and these are times when you see some of these kind of closed off behaviors that you really want to listen, but definitely paying attention to that nonverbal communication. And then keep them coming back. Empathy is huge, and really understanding what empathy is. I mean, I think for a lot of us, we can sympathize with the patients we're seeing, but really trying to understand the situation and really think about yourself in their shoes, but really think about what they're dealing with. Remember their name and use it. I'm not good with names. When we did group classes, on the first class, we would go around and I would write down their name in whichever seat they were in, because I'm just not good. I didn't remember them till by the fourth session, I knew everybody's name, but I wanted to make sure I could use it. And so that's what I did. So find little tricks. Know that every person has a different story. You might hear a lot of similar stories, but each person is different. Thank them for coming in. Thank them for attending. You're grateful that they're putting their health as a priority. And make sure they don't feel like a number or research subject. Sometimes we can ask questions. They were just asked that question. I know in our clinic, there were a lot of repetitive questions. Sometimes there's reasons for those, and sometimes we just didn't bother to look at the medical record. So being sure we know what is available to us, what are they being asked before they get to me. In a diabetes education program where I worked, people came through the clinic. They were asked a series of questions. I didn't know that until I said, hey, people are getting really frustrated. Can I just kind of see what happens? I was fairly newer. So walking around and sort of what does it look like? They came in, they downloaded their meter, they talked to the medical assistant, things were entered in. They'd come to us and we'd ask them some of the same questions. So we were able to consolidate that. Or maybe they were, for diabetes education, they were already in our clinic fairly recently. So some of the other questions we were asking were already documented. So kind of review those. And when you meet the person, determine, does this jive with what I read? Or if there's any questions, you can ask again. And then just embrace the unexpected. I think our reactions, it's sort of hard to react calmly when someone asks you something that you're like, oh my gosh, I wasn't expecting that, which happens all the time. And so I just got used to sort of reacting, sort of sincerely and just answer the question. You kind of have to get your poker face a little bit, because sometimes you're going to be asked things that are like, oh my gosh, I did not see that coming and I don't have an answer. So preparing yourself for the unexpected. And just to look at this is thinking about, why don't people come back? And one of the most obvious things, and we all go through this, is, did they remember? Reminder calls are super important. Remind people, don't forget about your appointment. With our program, we said we did reminder calls for the longest time about a week in advance. Didn't really help, but we did them for years that way. One day I said, our medical assistant who did the reminder calls, this was the thing she loved doing. And she just liked talking to the patients, and she'd get them on the phone and educating them about sort of what the classes were going to contain and all of that. And she's like, Sasha, I think that we're calling them too far in advance. I think it'd be better if we called them the day before. I'm like, okay, give it a try. Why not? What did we see? We saw more people were showing up. And when she'd get them on the phone, like, oh my gosh, I would have forgotten about that. I'm so glad you reminded me. And sometimes even the day of the appointment, so we got to know our patients and we kind of knew people that might forget. So she might go, oh, I know this person that sees Sasha, and she's often no-shows, but she's kind of forgetful. So I'm just going to throw in a reminder call this morning. And sometimes that would help. Another thing is making scheduling and rescheduling appointments easy. When we first started, our patients could call and cancel an appointment, and they would cancel it. And then when did they come back? Unless they made the effort to reschedule that, they weren't coming back. So simple thing we did with our call center that we said, hey, if anybody calls to cancel diabetes education, please offer to reschedule them. And if they don't, please send us a note so that we know who didn't show up and we can kind of look into that and support them. So some of these things are pretty straightforward, but in the midst of a busy clinical day, you don't think of these things. So being sure that you're making scheduling and rescheduling easily, you're avoiding cancellations, and just doing some reminder calls and thinking about the cadence that makes most sense. In our clinic, like I said, it was the day before was better, but if they had an appointment on a Monday, Fridays didn't work, so she just came in early and did those in the morning. So really thinking about your population, when are they home, and how you're going to do that. Sometimes some populations, it might be good by a text message or something else, but we found phone calls. One more note on that I'll say is our health system went to automated reminder calls at one point. And all of a sudden, people weren't showing up. And our health system was very adamant that everybody was part of this system. And our team knew for sure that when Jennifer, our fabulous medical assistant, was so friendly, that was part of the community, a pillar of the community, would call people, they would light up. She lit up, they lit up. It was just a good conversation, and she just looked forward to this part of her day. We knew that this automated call wasn't working well. It was like a computerized call. And when I listened in, it wasn't even full. It would like cut off halfway through. So we begged and begged. We said, our attendance is going down. We had data to show people aren't showing up since you implemented this. And they allowed us to be an exception and pilot this. Well, we knew what was going to happen. And we were proved to have, personally called, our medical system was able to personally call people for our reminder calls from then on, and they just turned that function off for our visits. Now, for provider visits, it wasn't as big of an issue, because if you've got a doctor appointment, you might have waited 6 months to get that, you're probably going to show up. But diabetes education can often be a little bit different. And then, why didn't they come back? You've done all these things and you're still trying to figure out why didn't they come back. Sometimes you might look at some of the things we noticed when we were looking into this was we had about 30 providers in our clinic. And I noticed that, at a couple of providers, their patients always showed up, and sometimes begrudgingly, but they were like, this doctor made me come. And you could tell they didn't want to be there, but they showed up. I had other positions where I noticed, gosh, their patients just don't seem to show up. Like 50% of their patients show up, while this other doctor, 100% of her patients show up, even if they're mad about it. So what's the difference? So I talked to our physicians and I said, hey, you refer a lot of patients. Can I just kind of sit in the clinic day with you and just kind of see how that goes? So the one who everybody referred, when I went and sat with her, the conversation was, okay, we have this wonderful diabetes education team, and I can't tell you everything, but they can help you with the day-to-day stuff. They can answer a lot of the questions I just can't or have the time, and they can spend a lot more time with you. The conversation was really rich about the value of our team. She used our names. I want you to see Sasha, or I want you to see Kim. It wasn't impersonal. It was very personal, and we were part of her team and her family. Okay, well, this is interesting. All our patients show up. That's good. Went to the next one who had very bad retention. And she said, I need you to go to see diabetes education. I put in a referral. Okay, bye. That was it. That was it. Sometimes she didn't even do that. I would think, did she even refer to us and follow out to check out? They're like, yeah. And checkout clerks would say, hey, do you want to do diabetes education? They're like, what? What are you talking about? No, I don't know what you're talking about. Did she say it? Well, she put in a referral. I don't know what that is. So what did we have to do? We had to learn some of these things. And what we did was, some of our physicians were like, I don't have time for this. I'm like, okay, that's no problem. We will find another way. We went to our checkout staff. They were very enthusiastic, like, oh, we wondered why people just didn't come in or didn't want to schedule. We gave them a little bit of a script to share and told them we had them help personalize it. We also trained our physicians, and some of them got really good at sending quality referrals and others didn't, and we kind of worked around it. But there's always a way to kind of find a solution. So think about, are there trends you're seeing? For us, we really noticed this trend based on provider. There might be other trends you notice. Gosh, nobody shows up. All of our appointments are at 8 a.m. Why doesn't anybody show up? Maybe that's not a good time. So really think about all the different factors that you might know of. And it's probably not rocket science. It's just a matter of sitting down and maybe even asking some questions of your patients that didn't show up. And again, that's my next slide, is ask referring providers, why did you get anything? Maybe you see this Dr. Jones and their patients just aren't showing up. Do you know why? What was the deterrent for them to come? And you might learn a lot. And if you are able to talk to the person who didn't show up in FQHC, that might be easier. They might be, in other visits and you get to catch up with them. Find out what it is. Every little bit of feedback can help. And really showing that you care and you want to call and reschedule the visit, that can even make a big difference. They may have thought, well, I canceled and I thought someone would call me, but they didn't. So it must not be that important. So now I want to move on to just a little bit of a different topic and talk about some of these nonverbal cues. And this little video is just going to talk about language and just the importance of how we communicate with people.
Words are powerful.
They create reality.
Words can empower,
Or words can blame,
Shame.
or judge.
So the language we use in healthcare matters.
I am a person with diabetes.
Diabetes doctor.
Diabetes educator.
I'm a person with diabetes, and language matters to me.
Use your voice to raise awareness about the language we use when talking with and about people with diabetes.
It's hard work managing a chronic condition.
It's 24 hours a day, 7 days a week, with no vacation.
With no vacation.
Some words we use in healthcare
Can make living with diabetes much harder.
Words like sufferer,
Non-compliant.
diabetic, non-adherent,
Brittle.
Or uncontrolled.
and words that imply that you should do better.
Or work harder as if they're not doing their best.
And words can make people feel
judged, frustrated, anxious, labeled,
Oversimplified. Dismissed.
Disrespected,
Misunderstood.
Embarrassed.
discouraged,
Accused.
Guilty.
blamed,
Shamed.
That is my fault that I have diabetes.
That I'm lazy.
That I don't care.
Like I have a character flaw.
or that I've failed.
It's time to change the conversation.
We can use words that are neutral and non-judgmental.
We can use words that are based on facts, action, and biology.
Words that are free from stigma, shame, or blame.
Words that do not judge. When we raise our voices together,
we can change the way people feel.
I'll feel respected, cared about, valued, not judged, understood, listened to, treated as an equal.
They'll feel that they're important.
that they are included in the conversation.
that they're not just an illness or a disease.
But simply a person.
And when we change the way people feel,
We can make diabetes easier to manage.
First and foremost, I'm a man,
Wife.
Father,
I'm a son.
Friend.
professional.
Person.
and I just happen to live with diabetes.
I live well with diabetes.
I can do anything I want to do.
So let's raise our voices.
Together, we can make a difference.
Let the world know language is important to you.
Because words are powerful.
And language
And language.
And language matters.
All right. That one is just a couple years old. As you can see, some of the language, we have changed our title, but I just think it's such a powerful, powerful message. Now, we don't want to be the language police, okay? We all slip up. You know, we all say things that we're like, oh, but it really is just an effort. ADCES has some resources. I'm going to share a tip sheet here. You'll be able to access this on our website for free, and really talks about how to use person-first, strength-based, empowering communication. Really enhances motivation, improves health, improves well-being. If you feel heard and you feel respected, you're motivated, right? If you don't, it just kind of can beat you up. And so we're all human. So just there's some resources here that may be helpful, but again, it's always a work in progress. Now I'm going to talk now about the ADCES 7 self-care behaviors framework. So the ADCES 7 is a person-centered, shared decision-making approach to care and education, really allowing individuals and those who support them to identify and facilitate overcoming barriers to care. The 7 self-care behaviors are the same, but the content's been updated fairly recently. So I want you to notice something really important about this change. If you were familiar with the ADCES 7 or the AAD 7 before, this infographic really highlights something important. When you look at this infographic, I want you to notice what is in the center. Healthy coping is centered for a reason, because we really need to place the highest priority on assessing and assisting the person with being healthy and coping with their care first, before we can get to the rest of all these behaviors. Because if your coping is not, if you're not accepting that you have diabetes, accepting what it might take, you're not going to be willing to make some changes to your diet, your eating, or be more active or taking medication. So really think the center of this is all about healthy coping. And we're going to go through all of the behaviors. So this is 7 self-care behaviors really lead to effective self-management through improved behavior. This has been researched. So this isn't just an idea or a concept. It's a framework that can help you guide your delivery of effective person-centered care, collaboration, and goal setting, can provide evidence-based model for assessment, intervention, and evaluation, encourages strengths-based approach, and acknowledges an acknowledgement of the whole person in context of their life and relationships, and helps to provide standard vocabulary for assessing, identifying challenges, setting goals, solving problems, documenting issues, evaluating success, and making improvements over time. So behavior change, I mean, just to begin with, what to do, how to do it, it's important to do, and you want to get to I can do it. So behavior change is a unique outcome measurement for self-management using the ADCES 7 framework. The goal is to improve overall health status by empowering the person to acquire knowledge, acquire skills, kind of how to do it. The knowledge is what to do, acquiring skills is how to do it, and then developing problem solving and coping skills to overcome any barriers to self-care, and developing strategies and confidence to perform the self-care behaviors they want to achieve. It's a quote I've heard that people with diabetes, and I don't know, this is a total research, but anywhere upwards of 200 decisions they have to make each day for self-management of their diabetes disease to be healthy. So thinking of all those 200 decisions, no matter what we do, we just can't be with them all the time. So we need to empower people to know when they need to make a decision, whether it's what to do or when to call the doctor. The empowerment model grew out of traditions of community psychology, adult education, and counseling psychology. Empowerment's defined as helping people discover and develop their inherent capacity to be responsible for their own lives and gain mastery over their diabetes. The empowerment approach is based on really the principle that the choices that have the greatest effect on health and other health outcomes are made by the people with diabetes, not their healthcare professionals. And individual people with diabetes are in charge of their self-management and are the primary decision makers as they own the consequences of their self-care behavior. So just really want to really think about the empowerment model. This is how I was trained by one of the gurus in Michigan. So I've really embraced this, and I think it's a really good model. And there's definitely research on that. So let's talk about these 7 behaviors. And I'm keeping an eye on time because I want to make sure we do have some time for questions. I may zip through these pretty quickly because this is sort of a sneak peek into our presentation that we'll be talking about a little bit later at the Stream Forum. But again, start at the center, really getting to know someone. You don't have to ask, how are you coping? That simple question is, what's the toughest thing about managing your diabetes? I almost can guarantee you will get there. So keep in mind, you're not always asking people specific questions, but you're thinking through, oh, this is telling me they're really struggling. Maybe they don't have support. Maybe, they don't feel safe anywhere to be active. They don't have access to healthy food. All of these things you can learn sometimes by that simple question. But the 7 care behaviors are healthy coping, being active, healthy eating, taking medication, monitoring, problem solving, and reducing risk. Reducing risk and problem solving often come a little bit later because they're a little bit more advanced. Or when someone's first diagnosed, we're talking about healthy coping, healthy eating, being active, and taking medication. Those are kind of the center. I'm going to go through just a few healthy coping assets. Thinking about problem solving. We're thinking about some individual, family, social network, community, and other assets that support healthy coping in your community. So I want you to bring this to your center, to your community, and really think about what are the resources. Facilitating stress management, obtaining positive support and peer support. Online peer support communities can be helpful. And for some people, they're not. Sometimes they can be discouraging. They need that in-person, contact. They may need to see people, especially after this pandemic. People want to get together. They're missing that social interaction, motivation and decision-making. And then that growth mindset for relapse prevention. The growth mindset is believing you can do it, kind of as opposed to sort of the fixed mindset where it's just sort of like, nope, I've never done this before. I'm not going to be able to do it. So really think of that as it's just a matter of learning and becoming that. When we're talking about healthy eating, I want to talk about some positive messages because when it comes to positive messages around healthy eating, we often have to overcome a lot of misconceptions. Everyone has an opinion or preferences, but it's really up to the individual to choose what works best for them. Now, I'm a dietitian, a registered dietitian. This is near and dear to my heart. I do not give people advice. I do not tell people what to eat. I offer them education. I answer their questions. And in general, I want them to choose foods that are part of their culture, that are part of foods that they love, part of foods, the foods that they enjoy every day that they grew up with. There may be some modifications. Maybe they say, hey, I know this isn't healthy and I know it's full of something. Can you help me make this a little bit better? Maybe I can tweak my recipe, but I don't quite know how. Really, healthy eating should be colorful. Some of the healthiest foods are the most diverse in color and flavor and texture. And the foods they are eating should include the rainbow of colors. For most people, this is foods that you grow up with, and they are part of your culture. There is not any single diet that you should be telling everybody you should do this. In fact, if you find the word should in your conversations with people with diabetes or your patients in general, you might need to give that another thought, because how do you feel when someone says you should do this instead of what do you think about this? Kind of reframing things. I'm also going to talk about being active. So being active is really, what are some of the individual, family, social network, community outlets that support healthy, I should say being active in your community. Sorry, that little typo. How does your community make activity the easy choice? I live in the Washington, D.C. area, and I feel like it's probably the most, I've never lived anywhere. I grew up in Michigan, never lived anywhere where being active was so easy. Everywhere I go, there's walking trails, there's fitness places. That is not how it is in every community, and probably not all the ones that you serve. So take note of those resources. What are people's options? How can people access these resources safely in their community? I'm going to move a little quicker here as I'm looking at the time, but taking medication is one of the others. And even if you're not, you may look at the person's chart and you're like, I'm not a prescriber. I don't know all this, but it's just assessing the person's understanding of how the medication is to be taken correctly, and then barriers to achieving that without judgment. When we ask someone, how are you taking your medications? It shouldn't be, are you taking the medications as your doctor told you to? This is not a good way to get a sincere answer. They're going to go, yep, I'm doing what my doctor said. But you might say, is there any time that you ever forget to take it? Things like that. Non-judgmental questions, and really trying to get to what is going on so you can help. When we talk about monitoring those assets, it's, sometimes it can be tracking weight, sometimes physical activity tracking. Maybe they have a smartwatch or a fitness tracker, blood pressure checks, blood pressure monitoring. There's a lot of different ways that you can monitor all of these activities. So monitoring is one of the 7 self-care behaviors, but there's a lot of different things you can monitor. And it might not always be food logging. We might not like to do that. So just think about what is the need and what might be helpful or motivating. And monitoring, I should say, should be informing the person as well as you. They should be learning. It's not so that they can bring a report to you as the healthcare professional. And I always would say this, if you're tracking your food, you're welcome to show it to me. But what I'm hoping is that you'll kind of identify some low-hanging fruit, some easy things that you're like, oh, I don't even know why I do this or that or eat this or that, because I don't really like it that much. It's just adding unnecessary calories or fat or whatever it is they're thinking about. And then problem solving. What are some of the assets with problem solving? Thinking about resilience, experience problem solving that can be applied to health, and supportive friends, peers, family, and community, and you as their partner in healthcare. We're going to talk about reducing risks, social support, resources, reminders, cues, rewards, SMART goals. We've all heard of SMART goals, but we don't have to refer to them that way. Sometimes people think, well, aren't my goals SMART? What are SMART goals? They're specific, they're measurable, they're achievable, they're relevant to the person, and they're oh gosh, I forgot the T. They're time-based. I'm sorry, they're timely. So it's not like I'm going to lose, weight. That's not really a SMART goal. The SMART goal is what you're going to do to get there and how often you're going to do it. So thinking about making things more specific help people get to goals. It's not about them being smart. It really is about setting smaller steps to get to those goals. So again, Let's remember, start from the center, make sure healthy coping is where you focus. And to frame that discussion, sometimes to get started, we've got a lot going on. Maybe you give someone a list of them and say, here's a list of the 7 self-care behaviors that help you take care of a chronic condition like diabetes. Is there one you want to talk about today? Asking open-ended questions. What have you heard about diabetes complications? What is your greatest concern about diabetes complications? What do you think a person can do to prevent diabetes complications? So these are just some sample questions that you can ask that really can help get people talking. And again, outreach methods and applying an interdisciplinary team approach with community health workers and promotores is thinking about where you fit in. Navigation to care, all of these messages and communications are going to help you no matter what role you're in health center, but providing community support, doing activities to build skills, addressing barriers and supporting facilitators, extending care, anything else. There's probably a lot of different things. And as we are, I know we're really short on time, so I just wanted to share, this is the people on the DSMES team that could be members of the team, really a lot of people. You need one person on the left at least, and then any number of people on the right. And it looks like Megan put in the chat more information about our DSMES accreditation program, so you're welcome to go there. And if you email us at DAP, I'm going to share that next. This is my contact information. Feel free to reach out. I've got some hyperlinks to our resources. We have these ADCES 7 tip sheets. They do come in English and Spanish, and then other languages as well. And then our link to applying for accreditation. And I will turn it over to Sylvia for Q&A.